Well, I think the thing that sets the UCLA MS program apart from other institutions is that as a program director, I have made it a conscious effort to gear all of our research around the clinical work. And so what we do is a bedside to bench to bedside approach. We don't start with some molecule that somebody's read about in a paper that we think's cool or important, and that's it. What we do is we have this integration about what goes on in the lab and what goes on with the patients.
One of the really nice things about being seen at UCLA is you don't have access just to your actual neurologist, but to your neuroradiologists. You have access to our excellent physical therapists, our occupational therapists, and the whole Maryland Hilton Rehab Center just down the street. And we just have these specialties that are all within the system, know how to talk to each other, and can really take care of the nuances of MS care when it's beyond kind of one person's expertise.
We'll take things like a clinical observation like females are more susceptible to MS, or males do worse with disabilities once they get it, or actually aging is bad for MS. We'll take these things that the clinicians know and they deal with this every day, and we will move that into the lab to try to figure that out, to try to figure out why is that?
It's the case now that the majority of disability that folks develop through the course of their lives from multiple sclerosis is related to this disease progression, this slow, insidious development of disability. So a big focus of my research is in identifying imaging changes that could help us in terms of determining who it is that's more likely to develop progression. A second aspect of my research is in developing therapeutics to potentially help with multiple sclerosis related progression.
We don't want to do things that are just redundant, like if there's 3 interferons, we may not want to do the 4th yet interferon trial, because I don't think it's the best use of our patients' time and effort, and even our faculty's time and effort. We would want to focus on a trial that does things that's really going to move the field forward.
My specialty training during fellowship was, of course, in MS, but also in getting a real foundation in the way that we run clinical trials, the pros and cons of kind of each minute detail that we think about when we're designing a clinical trial. And so much of what's exciting here at UCLA is, again, that we have that really strong science background, and we have this huge opportunity to actually formalize the process in which we bring that experience over to clinic.
What happens to the patients has to drive what we do, and we have to prioritize our lab work to answering something, a question that is going on in the clinic with the patients that's really an unmet need. It's unknown, it's unclear, it's a problem. We have to address the problem that the patients are having with our basic research and try to come up with a solution to then offer them in a clinical trial. That's got to be the priority, and I've always made that the priority.